Equity and Inclusion Specialist here at CentraCare. I just wanted to thank everyone and all the peeps online for showing up for this community conversation. And I wanted to make you all aware of the partnership with this. There is Bashir sitting over there. CAIRO partnered with me. I wanted to include this. I had this idea for a community conversation, and in these 4 segments. And once I asked, I spoke with Mohammed, and they were on board right away for it. They felt that it was important for Black History Month for us to have this space and have these open conversations. And so I wanted to thank our partners for that. Give them a hand clap, everyone, because they deserve it. And I wanted to also let you all know that it's partly sponsored too by the African American ERG. While we planned it, the African American ERG were part of the sponsorship. And so here today we have Sarah, who is the chair, and I'm just going to hand it over to Sarah and let her say a couple of things.
Yes. So an ERG is an employee resource group. So it is the groups that help us kind of unite and give us that safe space at CentraCare. Good question. All right. And my name is Sarah Brooks. And I'm just going to go over the mission statement in regards to the African American Employee Resource Group. So our mission statement is to give a shelter and to shelter a creational platform to promote African American advancement and excellence by educating and inspiring employees at CentraCare and within the community. And I'm going to give it back to Miss Erica. Thank you.
Thanks, Sarah. So now we're just going to go ahead and get started. Our moderators are going to just take over from here, and they are Hani Jacobson and Dr. Teresa Reichert.
Hi, welcome everybody. Today we're here to talk about health disparities, which has always been such an important topic in our communities. And my name is Teresa Reichert and Hani Jacobson as well. And we're here to just open up the community conversation about health disparities with some of the panelists from our community as well. So to start, we'll introduce ourselves, and then we'll talk a little bit more about health disparities before introducing our panelists. So my name is Teresa Reichert, and I am the first diversity, equity, and inclusion transcultural nurse at CentraCare. So my role is really involving diversity, equity, inclusion. I do awareness, teaching related to that specifically in nursing itself. And I combine over 18 years of nurse locally within the cities and globally within this role, as well as my education background. I used to be a nursing faculty as well. And so all of that has really been helpful in the role as I do some cross-cultural communication, education, as well as transcultural awareness, or awareness of just the impact of different cultures that we interact with specifically in nursing. So I'm really happy to be here. Usually I just describe my role as I help people understand one another better so we can care for one another better. So happy to be here, happy to be on the panel working with Hani and all of these wonderful panelists.
Hi everyone, my name is Hani Jacobson. I'm a community health nurse at CentraCare. I strongly advocate for health equity and justice. I've been with CentraCare for about 10 years, a little over 10 years in nursing. I'm passionate about this work and the possibilities that lie ahead and all the amazing things that we're going to do in the future, because I believe together we can achieve a healthy population. It will take all of us to overcome generational trauma, systemic racism, and the current health disparities that we have. And more importantly, we will build a healthy community.
So today's conversation is about health disparities, which means that when health resources are shared among the community, that amount is shared differently and often unequally within different groups within the community. And some groups will get more resources and some receive or have less. And these differences in how the resources are split among the groups often happen because of systemic inequalities within communities where rules or practices or policies are created in a way that benefits some and disadvantages others, such as maybe a way that a community has designed or placed schools or roads, or workplace expectations about what is or isn't professional, or common beliefs or relationships between people within a community, such as who works, who stays at home, who can or can't own property or get a loan. And these differences are often things that we do have the ability to prevent when we're aware of them.
Differences in being able to access or receive health resources can also happen because of social determinants of health. This is just a long, fancy way of saying that there are non-medical things that also impact someone's health and well-being. Social determinants of health are conditions where people are born, grow, live, work, get older, etc., which shape their daily lives and their health. Examples of this might be access to high quality education, right? Depending on your zip code, you could get a crappy education or not. Being able to afford things like healthy food, healthcare, housing, living in neighborhoods with safe air, water, and streets, and social things like racism and discrimination. Like Teresa has mentioned earlier, health disparities are differences in health and well-being that we can prevent, especially when we look at social determinants of health around us. When we take time to consider social determinants of health and disparities, we often see differences in the burden of disease, like who gets disease or gets sicker with diseases, such as higher rates of long-term or chronic disease among low-income families and communities, shorter lifespan compared to others, more financial strain that can cause higher cost of health, less access to mental health services. I'm sure many of us know what that's like, or know someone that knows what that's like. And the cycle of poverty and discrimination. So we want to understand how we can break that cycle and make it a possibility for a better future for our community.
Yeah, and like you mentioned, Hani, some of the common social determinants of health, the factors that contribute to health disparities, are socioeconomic status is one, which just means that people can or can't pay for or afford things that lead to a healthier lifestyle or access to healthcare services. Another is education. So usually the more education you receive, the better you're able to understand really important healthcare decisions and make the best choice for you. And location. The fancy word for that is geographical access, but it just means that where you live matters. And whether you live in a rural area versus an urban area, or where you live within those areas, can significantly impact or make a difference in what you have access to and the quality of the care that you have access to. And then another important social factor that Hani did mention already too with health disparities is historical racism in our society and in medicine in particular too.
So today we're going to talk about the impacts of health disparities on marginalized communities, how marginalized communities are most commonly affected by SDOH, or social determinants of health. We will start by introducing our amazing panelists and listening to them, and then we welcome audience participation towards the end. We will have an opportunity for question and answers, so have some good questions later for us.
Yeah.
Go ahead.
So first I'll introduce Dr. Jaden, if you're able to. So Dr. Kim Jaden is a family physician who has practiced in central Minnesota for over 20 years. She also earned a master's degree in public health from the U of M in 2018, which, if you remember, is right before the pandemic began. She also is serving as the medical director for the community health at CentraCare and has been working as a medical consultant for the Stearns and Benton counties and also Wright County since last year. She sits on the board of directors for the Minnesota Medical Association and has chaired the Public Health Committee, and is also currently the chair of the Youth Chorale of Central Minnesota Board of Directors. Dr. Jaden was selected as the Minnesota Family Physician of the Year in 2019 and is the wife and mother of 2 young adults and 2 dogs. Among her greatest accomplishments, she counts the work that she's done with our local public health and local and state community leaders working on health equity, specifically around some of the vaccine work in the last year.
And I'll introduce Dr. Tenbit. As Ucare's Executive Vice President and Chief Medical Officer, Dr. Tinbit Imaru brings a passion of improving health outcomes for underserved and historically marginalized communities. Dr. Imaru leads the Medical Director, Clinical Services, Mental Health and Substance Use Services, Pharmacy, Population Health, and Quality Management departments. Previously, Dr. Imaru was a critical care neurologist and Chief of Department of Neurology at Hennepin Healthcare. Dr. Imaru was named a top doctor by Minnesota Monthly in 2018 and 2020, and among the top docs and rising stars by Minneapolis St. Paul magazine in 2017 and 2018. She serves on the boards of Minnesota Board of Medical Practice, Creating Healthy Communities, and is a member of the Minnesota DHS Health Services and Advisory Community. Welcome.
Harla Dirye is a visionary community leader whose journey into public health began at an impressively young age, and she quickly ascended into the role of the community health supervisor at the Center for African Immigrants and Refugees Organization, or CAIRO. Academically, Saharla is an alumni of St. Cloud State, where she earned a bachelor's degree in psychology, complemented by minors in both human relations and international relations. And she has also attained a community health certification, an achievement that underscored her determination to contribute significantly to community well-being. So she's driven by a deep-seated passion for public health, and she's collaborated with a diverse range of organizations, notably the Minnesota Health Department. And her contributions there have been substantial, particularly her involvement in vaccinating over 700 community members in the past year, which is an effort that just speaks volumes to her commitment to the public health initiatives. So she's been instrumental in pioneering educational programs such as the first ever Somali diabetes prevention program and the SAILS program. And these initiatives reflect her innovative approach to public health, promoting lifestyle changes and also increased physical activity and improved nutrition while carefully preserving cultural identities as she does so. As a first-generation immigrant, Saharla is acutely aware of health disparities that can affect immigrant communities, and her work is fueled by a resolve to bridge these gaps and ensure that health inequalities are addressed in a manner that both respects and retains cultural traditions. So please welcome our panelists. Yeah.
All right, now we'll start with our questions. And we will give each, you will all get to answer the same question. You have about 1 minute to 2 minutes to answer each question. But if you definitely, have something important to say, we definitely want you to say it because we're here to learn and to listen to your experiences. So when we talk about health inequities, social determinants of health is an important part of the conversation, right? We talk about that a lot at work. We can't really talk about health inequities without that subject. So what are social determinants of health, and how are they connected to health outcomes?
Thanks. Thank you to CAIRO. Thank you, Erica. Thank you for putting this on and inviting us here. I think you all just laid out the social determinants really, really well. I don't know that I can add anything to that conversation, but there was one thing that you said about your zip code. I just was listening to a professor from Rush University, and if you live in the Loop in Chicago, so that's a geographic area in Chicago, your life expectancy is 80 years old. If you live outside of the Loop in Chicago, your life expectancy is 60 years old. So they are geographically very close, right, but have very different resources, and how that affects communities and wellness. And one of the other things I wanted to just talk about was groceries. We were just having this conversation before we started. But food security, right? It's not just, is there food to eat, but is it nutritious? Right? Is it low calorie, really nutrient dense food, or is it McDonald's, which likes to set itself up in lower income communities? And then are the foods that are available in my grocery store part of my culture, right? Do I eat meatloaf and mashed potatoes, or do I eat something else? And And how do you educate folks about the nutrition piece? And is there a market nearby? Do I even have an option? I was actually listening to another podcast. There's Kroger grocery stores, which is huge. I guess they own several different names. But they have a program where you can use your SNAP benefits to get groceries delivered to your house. Like, how awesome is that, to pick out some fruits and veggies and have them delivered to your house without having to take 3 buses to get to the nearest grocery store? So those social determinants really do affect your health. And I will stop. I know I'm over a minute, but obesity, heart disease, diabetes, cancer, right? Those are the biggest chronic diseases, all about nutrition. So, and all these other social determinants. So I will let other people talk.
Okay. Can everyone hear me? Okay. So when people often think about health, they kind of think about it from this one dimension where they think, oh, if I eat healthy, if I take care of myself, if I'm active, then I'll be able to live a long and happy life. But each person is born with certain determinants that may lead them to live in a certain neighborhood, eat certain foods, have a certain education that overall affects it. So I like to think of health as some big circle, everything interconnecting. A person's education, whether that is quality or not, whether they are able to achieve an education that will further their career, will determine the type of food they have access to, the type of neighborhood they live in, whether their neighborhood has crime or violence, whether it's safe for their children, whether their housing might have mold, which might lead to asthma and other diseases that might affect their children's health and their own health. So I will allow the next person to talk because I feel like I could go on a rant if I continued.
Thank you, CAIRO, and I am honored to be here amongst these panelists. I appreciate the fact that you've put up this. I think this is an opportunity for us to continue to send the message that health disparities are something that we should work on and that we can change. The way I define social determinants of health is more like social drivers of health. At Ucare, we make sure that we avoid the word determinants because it sends the signal of that these are fixed issues that we cannot change. I'd like to think that every single one of us can impact these things. These are complex social factors and systemic barriers that were put on by humans, right? And so we can change them. One of the examples that I was going to bring up is how systemic racism actually is directly connected to health disparities, particularly, this is Black History Month, particularly to African American and Black population in the US. So in the Twin Cities, since I'm from the Twin Cities, there is a neighborhood, Summit Hills, which is in St. Paul. It is mostly of white, very wealthy people. The life expectancy there on the average is 86 years old. Walking distance, there's East Rando. The life expectancy there is 65, and this is on the CDC's website. Now, you would ask, why? Right? In order to understand the impact of racism on health disparities, you need to understand how we got there. How we got there is, so the Rando neighborhood in the 40s and 50s used to be a very thriving African American community. And due to redlining, and particularly when Highway 94, one that we just took here to come from the cities, was built, it actually disrupted that entire neighborhood because it passed directly through it. And that, the impact of that still is seen decades later by this life expectancy. It resulted in not having access to fresh produce grocery stores for many years, transportation, lack of good education, and you don't have to go far to see the difference in different neighborhoods with access to all these things that may not be health, but they have direct impacts to health.
So as a nurse, when I was in nursing school, I had to do some projects where I taught people in the community about different health conditions and how to help and how to treat them and things like that. And so I gave an A+ presentation and created one. But as I looked out into the crowd in front of me, I realized that all of that information was really good, but it was completely useless to the group that I was teaching, because if I was recommending healthy food, they didn't have easy access to the food that I was recommending, nor could they afford the things that I was recommending. The medical care, if they got sick, wasn't something that was easily accessible to this community in particular. And in this community, too, they cared for their family members as well. And so some of the recommendations I was giving for distancing didn't work for the family relationships and the living situations that they had. And so for me, I realized that lesson was really an experience for me that taught me about the blind spots and biases that I had, which impacted the care and the trust that I could have given to that community. And I could have been a lot more helpful and built trust quickly. And it taught me that, again, as a nurse, I couldn't just assume trust from the people that I was caring for. I had to build that trust and grow that trust. And so that's something that I learned, and I wanted to share that quick story just because so often in these discussions we hear people talk about systemic things, which can create health disparities like we mentioned in our introduction. But I'm really curious, can any of you, or are you willing to share a story of a time in your career when you encountered health disparities or social determinants of health, particularly if you can within the central Minnesota Black community, that was particularly impactful or taught you something? So are you willing to just share what you've learned related to that from your own personal experiences?
Start with me? Sure. So I'm a neurologist by training. I'm a neurointensivist. When I went to medical school, and I would, during training, when I saw a person who may be flown in from central Minnesota to the cities from a really severe stroke, I would ask, okay, they have high blood pressure. Were they taking their medications? If they weren't, well, we would just give them more, right? Unless you stop to think, well, why weren't they taking their medication, right? Well, you can't just push medications and add more medication. Oh, it must not be working. They must be taking it. It must not be working. It really, when I went to medical school, the emphasis was, yes, give them the right medication. It wasn't stop and ask why they're not taking it if they're not taking it. Can they afford it? If not, what are the resources that you, as a healthcare provider, should plug them in to make sure that they can afford it or to get access to those medication? So, what I learned was, make sure you advise people on healthy eating habits and healthy, exercising. Well, without really understanding the existence of food deserts, you can't really recommend to someone that they should eat healthy. Without providing healthy nutrition education, you can't really say, well, eat healthy. What does that mean to that person? And is it culturally appropriate, right? Pushing follow-up and preventative care visits without really understanding whether or not patients can afford the copay, because that they will have to pay when they come to see you in clinic. Whether or not they have transportation to come to the clinic, whether or not they understand, they have the necessary health literacy that they know that preventative care is important, whether or not they have childcare to watch their kids so that they can come to preventative clinics. So I, as a physician, before I really intentionally stopped to think about the whole person, I was mostly focused on the 20% of things that happen in the medical clinic building, right? The majority of your health actually is impacted by what's outside of the four walls of healthcare.
Okay. For an experience for me, back in 20 2023, when the pandemic officially ended, many people came into our offices stating that they lost their insurance because a lot of people became uninsured due to the fact that the pandemic was no longer an issue. Many people were on that medical insurance through the government, and some of them were able to stay on that, and some of them had to go onto a new coverage, and that's where my team came in, and we were able to apply for MinSure for them. So once they got that insurance, a lot of them were referred to doctors that were outside of their scope, and they didn't have that transportation. Or if they were able to get a doctor, the appointments were 6 months, 8 months out. Your illnesses are not going to stop just because you can't see a doctor. And on top of that, once you see your physician, they are prescribing you something that maybe your insurance might not be able to cover in full. So that's an issue that has affected many people within our communities, and I think that's a huge disparity that we need to work on, because if we want to solve the issue of illnesses, how are we able to medicate the individuals, and how are we able to make it affordable?
That's such a great example. I have just spent the last couple of days talking about prior authorizations with some of our elected officials, and when I talk about it from my standpoint, right? Like, oh, pulling my hair out trying to get this authorized, and the patient experience is, if you go to a pharmacy, you may not speak the language, you are told no. All that means is no to you, right? You don't know why you can't get that medicine that the doctor prescribed you. So that's a great example. I was just going to use the COVID example. The folks who got sickest early on were the folks who already had higher disease burden, right? So historically marginalized communities. They also had a lot more exposure to COVID. They often lived in multi-generational housing. They had to take public transportation. They had jobs where they could not sit behind a computer at home like a lot of us were able to do. And so they just saw the virus a lot more. Their bodies saw the virus a lot more. And then they had less access to health care. And so the outcome of that was, especially in those very early months when we did not know much about it, there were a lot of historically marginalized folks that got really sick. And in Chicago, I know I'm sorry to talk about Chicago all the time, but I just listened to this podcast. 72 of the first 100 deaths from COVID were in Black people. 72 out of 100.
Wow, I kind of knew it was bad, but yeah, that's putting it into a different perspective. Can you all hear me?
Yep.
Okay. So the next question is, in your roles or your work, what role does systemic racism play in perpetuating health disparities? In your experience, have you experienced situations that are due to systemic racism, structural racism, those other disparities? Can you share with us a time that you actually faced systemic racism?
Well, I can give lots of examples that have come out in the last several years. There were a group of medical students who wrote an article in the New England Journal about how all of our illness calculators are flawed. When I was in medical school, I'm going to date myself here, basically race was biology when I was in medical school. So risk factors for almost every disease, diabetes, high blood pressure, cancer, was being Black. And now we are learning that race is, of course, a social construct. It is not a biologic construct. And so it's these social determinants, this systemic racism, that causes bodies to break down and causes this higher disease burden. So I forgot where I was going with that. So specifically, kidney function test. So you know this well, but there's something called a GFR, which is a calculation of how well your kidneys are functioning. A long time ago, some fairly racist physicians did some studies saying that Black people had higher muscle mass, and so this calculation is different for folks who are Black. And as it turns out, this means that folks don't qualify for kidney transplants, or that we dose their medications wrong sometimes. And so this really bright group of medical students got together and they said, this is not right. And so we are re-looking at a lot of those things. Lung function test is another one of those things. That is, you get a different number based on what your race is, which again is not biology. So those aren't specific to me, but those are specific to medicine. So.
I love the fact that you added that oftentimes race is considered biology. I graduated 2022 from SCSU, and I took a nursing course in human biology. And in my textbook, which had to be maybe 10 years old, there was a passage that said, oh, black people feel more pain, less pain than white people. And then the answer was correct. And I was very shocked because I was just like, okay, well, that can't be possible. And I talked to my professor afterwards, and he's just like, yeah, it was just in the textbook. And even myself being a black woman, I've seen oftentimes that my experiences or my illnesses are belittled when I go to the doctors. And I've had an allergic reaction, and I was in the weight room for almost 2 hours. My throat almost closed up. I almost died because of that, and nobody assisted me or came to me. So I can't imagine someone who doesn't speak the language or someone who is more timid, how their experiences are.
Yeah, these stories are happening every day, multiple times a day, by every single person of color. I was going to talk about the kidney function test, but there is even a more recent example of that. During COVID, the pulse oximeters or the oxygen sensors, they were not picking up the level of oxygen from someone's finger if that person had a darker skin, because they were not tested on people of color. Right? And so even though your oxygen level was really low and going down, it wasn't picking it up. And so you didn't get enough attention right away. This was just during COVID. And so there is that. Specific example about pain medication management. As you know, sickle cell is more common in people of color, particularly those of us who are East African descendants, right? Pain medication management was historically not given more attention to anyone who was a person of color. And that is still seen today. And so, we can go on and on and on and on about this, but this happens unless every single one of us, particularly those who care for other people, stop to think about, why are we doing this? What are the questions we ask in the way we teach medical students when we say this is a 25-year-old woman versus this is a 25-year-old African American woman. Well, why does it matter? Right? But that's how we were taught. And so, there are so many examples. We would be here all night.
Yeah, there's a lot of unlearning many of us have had to do in our professional fields as well. I know, Saharla, I had to do a conversation with some of my employees when I was in leadership about the same discussion about black patients who, she said, an employee came to me and said, oh, do you mean like how you're paying attention to culture, like how black people need to be poked harder for an IV? I was like, oh. So, that was just 2 years ago, too. So we all face it in different unexpected times and expected times within our roles. So I thank you for sharing. The next question we have is, there's quite a range of health disparities that affect black communities. And in your experience, which health inequities do you see occurring most heavily within the black community here in St. Cloud, especially with St. Cloud being considered more of a rural community?
So I looked up some interesting statistics. So Minnesota Community Measurement is an entity that shows different preventative and wellness measures for the entire state. Showed that for care that was delivered in 2021, but was measured and analyzed in 2022, on the average, so compared to the statewide average, Black people had significant disparities in performance rate for 16 measures out of 18. These include Black people had lower colon cancer screening rate, lower asthma control, lower optimal diabetes control, lower vascular care, lower rates to follow up for depression, on and on and on and on. 16 out of the 18 Black people had significantly lower rates compared to the statewide average. It wasn't even compared to white people. It was to the statewide average. Particularly in this area, CentraCare has done, does community needs assessment every year. And the 2021 community needs assessment, actually, they looked at by gender, age, education, and poverty level. And one interesting fact I saw there was 20% of people who were surveyed said that they experienced discrimination. Applying for jobs, working at a job, receiving medical care, looking for different housing or apartment, applying for a credit card, bank loan, mortgage, shopping at a store, eating at a restaurant, on and on and on. 31% of those who experienced discrimination had lower income. So they were below the 200% federal poverty rate, compared to 15% who were above that or had a higher income. They were also younger, and they also had less education. And the point of this is, and this is happening in this area, right? The point of this is there's a compounding effect to structural racism.
So I love how you brought up the fact about preventative care and how important that is, and that how that can help with diabetes, stroke, heart disease. I work with a lot of Somali people in particular in the community with pre-diabetes prevention program, and that class focuses on making them more active. What does a healthy diet look like? Many of these people did not know how to prevent that even diabetes was preventable, and that's because no one told them that. Doctors would just label them as diabetic. They never told them anything about pre-diabetes. And if they did do were told they were pre-diabetes, oftentimes those who are interpreting that to them don't have a word for pre-diabetes. So they don't understand what it is to be pre-diabetic. On top of that, when we live in St. Cloud, I've noticed it's not very walkable. There isn't areas where you can go and walk and exercise for free. So when you combine that with the lack of groceries that provide organic produce or culturally competent produce, that's why we see an increase in diabetes within this community.
This is a huge problem, and it's a multifaceted problem. So if folks don't trust us, they're not going to come see us. If they don't come see us, they're not going to get their colon cancer screening. And if they don't have a ride to their colonoscopy or their mammogram or childcare, I mean, we've talked about these social drivers lots of times this evening. And I think what I keep coming back to is how to communicate in a patient-centered way. So, where are you and what are your social drivers in a way that I can help you understand prevention or early screening or those sorts of things. And it's a real challenge. I have been struggling with it for 20 plus years and will continue to struggle with it. And I change tactics every 10 days or so, and so I will keep doing it. And I'm just going to put in a plug for my team here that, when I miss these folks, if I'm dealing with their pneumonia and don't have time to order their colon cancer screening, sometimes my community health improvement team is calling them on the back end and saying, how are you doing? Dr. Jaden said you had some of these needs. And by the way, I can have this box sent to your house, and that's all you have to do to do colon cancer screening. So we are working on a systems. It's not always individuals. It is the system that has to help manage a lot of these disparities.
Wow. Okay, so the next question. In your experience, what are the biggest challenges you see to addressing health inequities or getting your patients to do what you want them to do?
Right. I wrote down two things. The list is long. I wrote down access. If you can't get in to see a doctor for 6 months, like you said, your problem's either gone or you're not around anymore. We just don't have access for lots and lots of reasons. And if you can't get into someone and develop a relationship, it's awfully hard to get your health needs taken care of. And then I wrote down trust too. We have a long history of racism in medicine, from the things you've already talked about to the experimentation on enslaved black women, which we learned a lot of gynecology from, and that is still felt and talked about and discussed, and that is really hard to get back that trust with Tuskegee experiments. I mean, the list is so long. So, I will take any advice from y'all how to build trust and and access.
I think the biggest issue right there and challenge with health inequalities and addressing it with the Black community is that trust part that you spoke about. How am I supposed to trust my doctors and my physician and my nurses when they're learning in medical school that I do not perceive pain the same way as my white counterparts? I am not going to go to someone who thinks that or even learn that. So really attacking those implicit biases, doing trainees and educations for physicians and doctors, as well as community members, making sure that we have doctors and doctors and nurses in the community, coming out to the community, working with community partners, having health education classes. For example, Honey and Liz, two nurses from CentraCare, come down to our space once or twice a month, and they teach health education classes in English, Somali, and Spanish, which is the three top common languages in our area. So that's quite nice to have.
I mean, it's kind of hard to add to what you both have said, but I think the biggest challenge, the way I see it, is to be able to sustainably address health-related social needs. And it's not, while we can help one person at a time by, if they are food insecure, by delivering meals to them, if they need transportation, by, helping them provide transportation at one time. What I think we need to change is to really address the systemic barriers and the structural racism that led to us having the disparities today. So until we go upstream and actually start addressing those issues, we will always have these issues, and we will always be doing one-off approaches. And so while it's important to help the person that's right in front of you, it's also important for us to think big and address the system.
So as we're thinking about getting bigger and addressing the system, healthcare providers and healthcare workers are a part of that system and play a big role. I know as a nurse, we make up one of the largest amounts of people in the healthcare workforce. And so I take that role seriously. So as healthcare providers or people who work in healthcare, how can healthcare caregivers and providers work towards reducing healthcare disparities in particular?
Everything starts with you, right? The one person that you can look in the mirror and be comfortable with. So understand why health disparities exist. Understand the impact of systemic barriers and structural racism. Understand how bias works. We all have biases. Unless you actually understand which ones are yours, you can't really fix them or you can't really address them. Taking personal responsibility in learning and improving how we deliver care. We talked about how each patient feels when they go and get, the care that they think they would get, but they don't get it. So there are trainings, trauma-informed care, trainings on what current issues affecting our patients, our communities specifically. And more importantly, though, as organizations, making community investments to improve the lives of patients and their families and communities, to be able to actually provide care for whole person, investments in community organizations. And I'm going to plug Ucare here. Ucare has provided grants to different community organizations, has partnered with community-based nonprofit organizations that deliver education, that deliver, various number of supports. I think that as an organization, that's what you have to do. But also really embed health equity into everything you do as an organization. Your workforce, make sure that you have diversity, equity, inclusion, anti-racism, and belonging in your workforce, right? Making sure that when you sit down to create policies and procedures, that you actually put health equity at the center of it.
I think we talked about this early in, can you hear me? Does everyone hear me? I think we spoke about this earlier, really making sure that we hit that systemic issue and working with policymakers as healthcare workers. I think going to the direct source, knowing who is in office, going out to vote. When you are voting, making sure who you're voting for has good healthcare policies and that they're really working for the community, because that's who they're going to be affecting. So it's really important that we elect people that are going to be helping the people that they serve. In addition to that, I think it's really important that we go out into the communities. I'm going to emphasize this time and time again. A good way to do that is working with nonprofits. Plugging my own organization, CAIRO. We work with the Minnesota Health Department and we get access to vaccines, which we have been able to give that to a lot of diverse communities. We also have been able to give incentives, so that really gets people out there. So we're not only helping prevent COVID-19, but we're also aiding in giving them financial care. So we give about $100 to each person we vaccinate. That $100 can go towards their meals, their housing, whatever they need. And that really overall helps that social determinants of health.
I'm super glad you brought up advocacy, because that is super important. Talking to your legislators, send them emails, let them know what you think is important. As a provider, listening to understand, I need to understand who you are, where you're from, what is your situation, and that's the best way for me to give you the best care. And I think that's part of patient-centered care. So much of our lives is like Kim-centered care, right? Like, you're late, you're gonna make me late, you're, whatever, I gotta keep going. So really spending that time and getting to know folks. And then the biases part, I will just say again and again that I love to say one of my biases is those flat-billed baseball caps. Like, I just have a bias against them, and I have to check myself, or a camouflage backpack. Like, I have to check myself every time I see one, and think, what is the story I'm telling about that person? But this is mental health, obesity, disabilities, people of color. I mean, we all have biases, and doing that work to figure out what are my biases and how am I going to try to mitigate those.
Thank you. Something I was thinking about is the amount of time you guys get with patients, right? Say, for example, you have 15 to 20 minutes with your patient who might have social determinants of health. And what can you really teach or do in 15 minutes? And then especially if you add an interpreter to that mix. So that's one of those policy things we need to talk about. 15 to 20 minutes is not going to be the same for a middle-class, well-educated person versus someone in marginalized community who has all those disparities. So yeah, we should talk about the amount of time and how providers get reimbursed is set up to make it harder for people, marginalized people, to get the care that they need. All right, our next question. So we know that healthcare providers cannot overcome health disparities alone. You guys have tried that, it didn't work. That's why we really push for working with our community organizations, community partners, those who provide medical equipment, medications, education to our community, because once they leave our clinic, we don't know where they're going. But it's great to see that a lot of systems are changing and making sure that, you know, we are forming those relationships and partnerships. So my question is, how do you see community partnership playing a big role in reducing health disparities?
So there were a few good things that came out of COVID. One of them is shopping online at Target and just getting that stuff put in the back of your car. The other was our connection with our community. We were at churches, we were at CAIRO, we were at mosques, we were at health fairs, we were at Juneteenth, we were at Pride Day, we were everywhere. And we had a Ucare bus came up and helped us one day when our own bus didn't work, and they were the nicest people. But all of a sudden, it's like there's not all that COVID money anymore. So you don't get that support anymore. It's a lot harder to get back out into the community and build those relationships. So great partners, local public health. I've heard you say Minnesota Department of Health a couple of times. They are great partners. CAIRO, Too Much Talent. Faith and Justice is a group that works with Spanish-speaking folks. I mean, it is really important that we have these relationships because those folks need to help us spread those words and spread those messages. We cannot do it alone. And they have that trust that I don't always have as a white woman. So really need those community partnerships.
Those nonprofits that you were speaking of, I really think they're a good source to go to. Many people who work in those nonprofits grew up in the community. For me, example, I grew up in St. Cloud. I went to high school here, I went to college here. So I really know the community and I know who I'm serving and what their problems are. In addition to that, working with seniors, they have been a great help for our organization in particular. They're very trusted in the community. They have a lot of knowledge. Oftentimes, they know a lot of ways to get out into the community that we wouldn't have thought of before. They are connected to the mosques and churches, and they're often like revered in those spaces. So really getting out to those seniors and community members and nonprofits is very important to build that trust.
I mean, I think you both said it well. Health disparities are not just the problems that could be fixed just for within the healthcare industry. It's much bigger than that, right? Because what affects your health is all around you. It's where you live, it's where you work, it's where you play, it's inside the clinics, it's outside of the clinics. Community partnerships actually are one strong way of addressing some of this. It's actually been Ucare's mission for the past 40 years. It's partnership with our community. We've been partnering with different community organizations, including faith-based organizations, barber shops, whoever is willing to partner to help support our members. We provide grants to small nonprofit organizations who actually work directly with people. So for example, we're funding Life Connections grant in central Minnesota, so right around here, Community Connections and Safe from the Start. It's partnering with public health staff and other community agencies that provide families across the 17 county area with formulas, first car seats, and baby supplies. We have worked with community organizations from food related to education and healthy eating habits that are culturally appropriate, a whole host of things. You can't really do this work without the community organizations that are facing those who you are actually working to support. The one thing that we've learned during COVID is to get members to take and accept the vaccination, they were actually having more success if the provider who was talking to members or patients about the vaccine looked like them and was from the same cultural background as them. So it's been very well studied and demonstrated that patients listen to their providers who look like them, nurses, doctors, community health workers. So sharing that same cultural background, knowing where you come from, knowing what your community is like, actually is the way to go.
Yeah, such a great point about some of the tendencies to believe people who look like us. There's biases, it's called the affinity bias or the similarity bias, that we tend to trust and feel like the people who look like us are not only more trustworthy, but those that we can believe and what they say is valid. And so that's a really good point that you bring too, that it all happens subconsciously, but it's a really important thing for us to recognize as we're working with our communities.
Can I just put in a plug here for kids and education and telling your kids that they can and should be doctors? It's like, apparently this happens like by the 3rd grade. If a child does not hear or think that they can be a doctor by the 3rd grade, it's not going to come into their mind. They're not going to work towards it. So I just think this is amazing, and apparently we need to move our high school conversation to our 3rd graders, because it only takes someone telling you that you can do it to help you do it.
Such a great point. Well, this is a point in this evening where we would love to invite questions from any of you out in the audience who would like to participate. So I'll come down, and you can either come up or I'll come to you, just as long as I don't fall.
You guys know already, generally when I see these two ladies, I'm asking for something. But so you guys already know that I think big, and I think the whole system needs to be scrapped. And we need to start looking outside of the box, because it's not just a fact of someone telling you can do something. They have to actually believe it. They have to believe in you. And so I'm wondering, like, why is it so difficult to do this thing called cultural clinics? And I've been trying to get this in this area, because it's a factor that, like you say, okay, people who look like you do better. It's because they already know the story. Okay, so you don't have to I can try to tell Kim all day long about what it is like to be me. And she try to understand, and she's really intelligent. But this is where experience is bigger than intelligence. And so I think we have to start looking at these things, because I know me myself, I live in the cities, but I didn't like being out in this area and not being able to see a dermatologist that looked like me, because someone else is not going to understand my skin. When I'm saying, I just want to get rid of the dark spots, I don't want to bleach my skin. I like my chocolate. I don't want it to leave, but I want this mark gone. And so it's like those different things that they can't understand. So it's like, I think that we've kind of like said, okay, with biases, like, we all have biases. People are used to hearing that. But it's like, what are we doing it? Are we, it's like we have to, in my mind, it's like you have to, like, out in front of a hospital, put it out there, just like high schools have their mascots. Put it out there, like they'll have a drug-free zone. Well, let's have a bias-free zone. You have to go about attacking it more aggressively, because those biases start from here. When the moment you enter into our school system, biases are going to get packed on every year. And we think about, like, the system of people of color being victims of the system, but actually, white people are victims of the system too, because they don't choose to have those biases, but they're put upon them from all these ages, and it just keeps getting layered on. So I think that we have to really be aggressive with seeing a new system for ourselves. And because that system is just going to keep putting biases back in there. You try to take it off, and it's going to keep putting it back on there.
Does anyone want to speak?
Was there a question in there, Erica?
She talked a lot about the systems and. So as you were listening to Erica, does anyone have any reflections from hearing her perspective that they would like to add on?
Yeah, if you can find them, we will hire them, right? I mean, it's not a large, I mean, there aren't enough doctors, period. And if we could clone you, that would be awesome. We would take 20 of her, please. But they're not out there, and so that's why we got to talk to them when they're third graders. And having a medical school here, and hopefully those kids that get accepted into that medical school are going to look like our community, and we are going to have a more diverse. Yes, and Sarah's in charge of that.
I have a comment on that. It's quite hard for a lot of people to become doctors because we don't have a medical school here in St. Cloud. So if I would want to, it's coming, but it's not here now. So it's not really easy if I wanted to do it. I would have to go to the cities, and that's transportation, that's money. It's already expensive enough. Can I afford that? If you're coming from a neighborhood where your parents don't make an income that is sufficient for your household, how are you able to afford medical school? So that's another problem we have to tackle. How can we make these jobs more affordable to obtain?
Well, and also let's talk about paid internships, right? People who take unpaid internships have the means to do that. There are a lot of kids in college who cannot do unpaid internships. Yeah. So let's make all internships paid.
Hi everyone, my name is Amina. I work with CAIRO as a space program supervisor. My question is, I moved to Minnesota 2017, and since I moved here, I noticed diabetes is really high in Minnesota. That I'm from California and then Denver, but I seen a lot of diabetes, especially in my community. I was an interpreter before this job, and all I was seeing was all mothers that are pregnant are diabetic, or So I don't see a lot of my community Somali person that is a dietitian. So we found a dietitian that like my sister became a dietitian. CentraCare reached out to her, and I know we need somebody that's a dietitian that speaks Somali and understand, but the offering is $27 an hour. Like, if we really want to care about those diabetics and we want somebody that speaks the language that are Somali person, why are we not, since they are in need, why are we not bringing them more, like giving them more, and make sure we get that kind of people here in Minnesota?
Yes.
I have a comment on that. For example, when your sister speaks Somali, is she getting that pay raise because she will have to be the translator and the doctor? So if I'm a doctor and I'm probably I'm a dietitian or a doctor and I'm being paid to treat my patient, am I being paid to translate for my patient? I sometimes don't want to go above and beyond, as I always want to help those around me and I want to be a better person, but I don't want to do extra work sometimes. I have to, this whole array of things waiting for me. And I feel like a lot of times Black people or people who are immigrants have to carry the burden of their people on their backs. And sometimes you don't want to be the hero. And it's kind of forced onto us a lot of times. So I feel like our white counterparts also need to partake in that and not force their diverse counterparts to be a translator, because that's not in their description and they're not being paid the extra dollars for that.
I was gonna add, I think the pay issue is important, but the fact that there aren't enough people who look like you is something that we should focus on, right, from before third grade. But it's, healthcare has so many different positions. You can be a dietitian, you can be a physical therapist, you can be a community health worker, you can be a nurse. We have to expose and create an opportunity for the young kids to show them that they can do any of those things. But it takes someone, you know, if they come, you know, I remember when my niece was very young, I think she was in first grade, we asked her, what do you want to be? Well, I want to be a teacher, but none of, you know, my brother, he lived in a suburb. Well, but none of the teachers look like me. You know, so it's seeing who is out there as a dietitian for the young kids to want to become that. And I think we should all create opportunities for that to happen. Can't believe it if you don't see it. Yeah.
I do just want to add one more thing. About 3 years ago, our amazing director, Rachel, from Workplace Diversity and Inclusion, did create a policy where bilingual employees do get paid for their language services. So, for example, if I use my language to educate a patient, I do get paid more. So that's for everyone in the system. And then, let's talk later. I want to meet your sister.
It's Ahmed. I am parent. I can't speak very good English, but I need to speak Somali. And then translator. Translate for me, please. Yeah. Gabar aan dhalay baa isbitaalka CentraCare waxaan umaleyn inta ku dhalatay 8 years ay jirtaa marka. Marka gabadhaas 5 bilood ka hor waxay beeshay dhagaha beeshay. Way hadlaysaa dhagaha laakiin waa markaan su'aalo weydiiyo ama aan dhakhtarinta u tagana wax jawaab ima siinayaan. Waxa keenay cost keenay. Marka Mayo Clinic-aan aaday.
I have a daughter who was born here. She's about 8 years old. When she was around 5, she became deaf, partially deaf, and she's having a really hard time hearing and understanding what I'm saying.
Marka Mayo Clinic markaan tagay waxay ii sheegeen kuwan clinic-gan waxay u direen bacyigan ii sheegeen laakiin waxay dhaheen kuwa kale qayb kala jirto oo waxaan baaraysa. Marka qaybta kale baaraysay waxay ugu dhaheen gabadhaada maxaa dawo siisay dawadii baan u sheegay dawadii markaan u sheegana way ii sheegeen ama kasliin iyo dawo kala ii sheegeen marka labadii dawo mid kamid ah way keentaabay ugu tiray dhaga la'aanta marka waxaan rabaa inaan ogaado reasonka ay CentraCare 8 sano gabadheeda jirtaa ay igu sheegi waayaan waxa koos gareeyay gabadheeda inay dhaga la'aado.
So he said that he took his daughter to the doctors in CentraCare, and then they told him that she was deaf. And then he took his daughter to Mayo Clinic to confirm that, and they confirmed that he was deaf. And they said, okay, what were you giving her? What type of medication? And the medication that he was giving his daughter at the time was prescribed by CentraCare, but CentraCare never told him that there was a possibility of her going deaf. So she became deaf over that medication, and Mayo Clinic confirmed that. So he's saying, why was I never told that? And I believe there was a bit of mistranslation on that part. I'm not sure, but
Amoxicillin and some other antibiotic. So basically, I think waxa dhehaysid waxa waaye education fiican patients-ka waa in la siiyaa daawooyinka la siinayo, right? Yeah. So how are patients educated on the adverse reactions that could come from their medications? When they come in, they're given a prescription, but then do you guys go through the possible side effects with them? As in his daughter's case, she lost her hearing.
Yeah, that's a terrible situation. I'm really sorry that happened to you. Every provider probably does it a little bit differently, and the pharmacist also has a role to play in that. So it sounds like a very complex situation, and we could certainly talk about it at a different time.
Okay. waxaa dhahday dhakhtar kasta si gooni ugu sheegaa patientkiisa nacam daawoon markuu u qoro daawadan maxaa kaaga imaan karo maxaa kala kulmi kartaa marka nacam arintaada qoys ahaan like si fiican ulama socdee dhahday laakiin gooniya u hadli karnaa si uu ogaado marmar farmasiyaha markuu qofka daawada ka doonanayo farmasiyaha waxaa looga baahan yahay inuu patientka isagana u sii sheego nacam side effects iyo wuxuu kala kulmi karo daawadaas laakiin badankiis daawo markay qoraan way qoraan waa iska baxaysaa dadka uma I mean intay fariistaan dadka uma sheegaan 15 daqiiqo bas ah haysataa markaa clinic ku jirtid hadduu cunugaaga infection hayo daawada ku qorayaan waa iska baxaysaa farmashiyana ma wala sheekaysanaba waa iska kaasiinayaan I was just saying most pharmacies don't have an interpreter on site. So when you go to pick up your medication, you just pick it up and you go. And in the provider's office, you only have about 15 to 20 minutes with an interpreter on top of that, which cuts the time to half. So in that time, you have to assess, figure out what's going on with the patient, do a prescription, and a short education. You really can't do a quality job with that. I mean, I don't care how we slice or dice that. You just can't. wax su'aal kale ku daraysa ma jiraa?
So my question is, this is Black History Month, and I would like us to talk about the health inequities structurally. So in St. Cloud, there's a lot of immigrant community on the state-issued insurance medical coverage. Many dental providers in St. Cloud here would tell the community members that they do not accept Ucare, Plus Plus, and all this state-issued insurance, and nobody's doing anything about it. And families travel all the way to Maple Grove, all this 40-minute to 1 hour and 30 minutes. So I want to use this opportunity to ask, what are we doing about that? I know CentraCare does a good job at accepting state-issued medical insurance card, but other providers, particularly dental clinics, do not. And that's my question.
Yeah, you know, unfortunately, you're right. Dental access is an issue for everyone, but particularly for kids who have disability, because then it's even more difficult to find dentists. It's an issue. I don't have an answer for you, but it is something that I hear from everyone when I talk to, what's your concern, for example. It comes down to, again, lack of providers, particularly if you live in an area that is not in a metro, highly populated metro like the Twin Cities. It gets even harder. If you lived farther out, for example, in northwestern corner of Minnesota, that's even worse. It's an issue. It's not having enough providers. It's the providers that are there not taking Medicaid. It's a number of different issues, and this is something that we all need to work on from federally, state government officials, as well as local. It's got to be all hands on deck.
Yeah, I was going to say the same thing. This is where your advocacy comes in. They don't pay well, and so a lot of times a dentist loses money when they see patients from that particular kind of insurance, and so they just have to make that decision. They aren't cruel and heartless. They need to keep their doors open. And so we were just advocating in DC about Medicare. They just cut physician fee payment another 3.5% on top of 2% last year. And this is not just what I take home, right? This is what it costs for me to have my lights on, and what it costs for me to have a medical assistant and someone answering the phone and all of those things. And they keep cutting and cutting, and there's just more and more older folks on Medicare, and it's just going to be harder and harder to keep our doors open. So please tell your representatives that we need to be paid adequately for the work that we do, and y'all, dental care is health care. If you have bad mouth of teeth, you are not going to be a healthy human being.
Oh, I just want to take this opportunity and say that I think the university, St. Cloud State University, is now starting a medical school. I think it's a good time. Yeah, is it part of what's called? Is it CentraCare that's starting? Yeah. Wow, good. It's even better. It's a good time for us to really take to heart everything we're saying and helping that institution to really implant the whole ideas that we're talking about. Dr. Temple talk about, you talk about, in educating the doctors who are coming and in the school they're teaching, the curriculum, to be kind of upfront of all these things that has been in the system for so long.
I think you make a good point that all of us and what we can or can't do is interconnected. Our work and everything we do is related. And so I think that goes to our final question that we have time for today, which is the closing question that we have for all of our panelists. And so learning about healthcare inequities and how to empower, how to advocate for, and how to care for people better is certainly the responsibility of the healthcare community. But we're stronger together, as we've kind of demonstrated in our conversation today. And so what are some of the things that those that are listening, either in the audience or online or in future conversations, what are some things that they can do to either empower themselves, to empower others, or to advocate for higher quality care for them and those they love?
You know, I think stand up for yourself. You know, if you don't understand, you ask. You ask until you understand. If there isn't an interpreter, you ask for one. It is your right to have one. You know, what I understand is unless you know what is out there, you never ask for it, right? Someone has to tell you that those things are available. And unfortunately, many people who should get these resources that they need don't know where to even begin to work to ask for the system, right? So it starts with education. I think every single one of us who understand how healthcare works in its current system, even if there are definitely opportunities for it to improve, is to continue to educate people so that they know what resources are out there, what supports they can get. But as an individual, advocate on your behalf. If someone tells you what you feel is not there or it's not real, you shout it from the rooftops until somebody else hears you.
Yeah, my biggest takeaway for you guys today is know your policymakers. I'm going to go back to that over and over again. They are the main people who are deciding what type of pay your physicians receive, what type of healthcare systems are in your neighborhood, whether you have access to the correct doctors and the correct medicines and pharmacies. Know what type of policies they have. Question them on those policies. Email them, write them letters, go down to the Capitol if you have to. It's really important to advocate for yourself and fight for yourself.
Yeah, those are both great answers. I was going to say similar to what you said about just go back. If you came in for belly pain and you still have belly pain and I have not given you a good answer for why you have belly pain, come back and tell me until I get it figured out. It is really hard, and it's really hard when you see 3 or 4 different providers because we don't all sit down and get the whole story, right? So keep coming back. That's one thing. Lean on your community. Reach out and get a parish nurse at your church or someone at your mosque who specializes in education about healthcare, and have kids science days, right? Like, let's get kids involved in science and let's get the rest of us to trust science again.
I love what you said about come back, but that also costs money. That's like another copay, and if it's not physical, you know you're getting billed for that visit. So access and calling your representatives. Well, I want to thank our panelists. Let's give them a round of applause. We want to give a special thank you to Erica Scott, our diversity specialist at CentraCare Health, for having a vision. I'll admit, when you told me about this day, I was like, girl, is that going to work out? But you made it happen. You had a vision and you brought it to life. This month-long event together to celebrate Black History Month, which should be every day. In the words of Maya Angelou, I'm going to leave you guys with, do the best that you can until you know better. When you know better, do better. Thank you again.
Thank you. So next week we will have, it's the housing conversation. And so for those of you who don't know, Minnesota has a large discrepancy. 25% of African Americans own their homes to 76% of their white counterparts. That is huge. Yet you don't have any programs to bring those equitable, bring that up. And that just is unacceptable. And so we need to have a conversation about that. Also, affordable housing. As we're, they're thinking about revitalizing downtown, well, how are you thinking about putting in, affordable housing in some areas? So I think that we all need to come out, like we've been saying, housing is a big part of health. And so we all need to come out. We all need to be advocates for ourselves. And then I'm hoping that don't just take these talks and go home with it. Figure out a way how to bring the community together, and we all make our voices known to, you have a mayor who has, a door across there. You have representatives. You have to speak out to those folks. So when I was thinking about this idea, I didn't think of it as a one-off, just at the end of this month, it's done. I hope that you all would see that you have folks that are willing to work with us, to help us to come together as a community. All we need is the voices. We need you. We can only create the platform, but you have to actually show up and make your voices heard. So thank you for coming out, and please come to next week. And then at the end, it is the fourth week is bringing the African American community and the immigrant African community together. So thank you.
We just want to finish with one more thing. We want to thank Hidik TV, our amazing camera guys, making sure they get our good sides. We want to thank CAIRO for providing us this platform to share our information. And we want to thank CentraCare, where health means everything. Thank you all so much.